Good afternoon. This is United Medical. Today is May 14th. Our UMACO weekly updates, live updates. We'll be discussing several issues. My name is Kemal Erkan. I'm the chairman of United Medical ACO. I'm going to have a couple of our leadership team and one also from business development. Tanner will be with me in a couple of minutes, and then Richa Shah will be joining me for the revenue cycle management and SPM updates, kind of the overview of what we have. So I'm going to actually go ahead and start the presentation from my side, and I'm hoping that everyone is able to hear us okay. If you have not subscribed for the channel, that would be helpful if you can, because this way you will be able to getting all the live updates right away. And then I am, okay, now on the PowerPoint. All right, let's start. So as I mentioned, we'll discuss the COVID-19 numbers and some of the COVID updates. We have some positive news and the RCM SPM overview with Richa, and then a couple of the other items that we would like to discuss with you is going to be around the healthcare quality and cost and the impact of the hospital, and that's pretty much what we are going to do today. So United Medical, from the billing services, we started as our core business, but we added so many different services, and today it's a turnkey operation for healthcare providers, and that's what we do in Delaware and also 27 other states. So I am gonna ask Tanner to join me.
Well, can you hear me okay?
Yes. Tanner, how are you doing?
I'm doing well. How about you?
Very good. And obviously, when we do these sessions, if I don't have the proper support from you and a couple of the other team members, so it would be impossible. So thank you. So I know you're going to give us the COVID-19 updates, so we can start with the Corona updates.
Sure. Thank you very much, Kemal. So some of the first updates that we like to go over are our path to herd immunity here in the United States, as well as locally in Delaware. We like to take a look at our vaccination rates, making sure we're keeping an eye on just how many vaccines are actually being administered and what pace that puts us on to get to our herd immunity. So there's some new news coming out of the CDC, which we'll get to and we'll touch on here shortly. But we did want to start with taking a look at our rate here locally in the state of Delaware. Vaccination rate is kind of fluttering up and down right now. We've dropped since our peak, kind of like back in the middle of April when we were just over that 10,000 doses per day mark. So we're still hovering around that just under 7,000 per day, which at this point is going to take us about 3 months to cover or fully cover 75% of the population here in the state of Delaware. So taking a look at the United States as a whole, we are starting to see that uptick just a little bit more with that rate kind of starting to get up again. We're kind of hovering around right over that 2 million dose per day mark, which again, with the peak here in the middle of April, corresponding similarly with the state of Delaware, we were just closing in on that 4 million doses per mark. But due to a number of different factors that we've discussed over the last few weeks, we're staying right about 2 million. So that's going to take us also about 3 months to reach herd immunity there. So what does this mean in terms of cases or new positive cases that we're seeing across the country? Continuing to push that curve down. You see here, we're peaking with new cases, new positive cases, that is. On a 7-day rolling average, we were still close to that 1,000 per million per day mark back in January. And we're really starting to see the flattening of that curve with the continuation of vaccination rates as they increase across the country. So as of this, I believe this data coming in from just either yesterday or the day prior, the United States is just over 40% of its population fully covered or fully vaccinated. 9 places or 9 states in the country are over that 40% mark. And that puts us on pace to get to that 75% mark, as we just mentioned, in about 3 months. So looking towards the end of summer at this point. So we'll continue to keep an eye on this, but this is definitely good news.
Tanner, we need some good news.
Sure. Then we do have some good news. This was, I'm sure everyone may have heard at this point, that just on, I believe it was yesterday, the CDC came out and now it's recommending that vaccinated Americans in most places, including indoors, are going to be able to lose the mask for gatherings, really regardless of size. So this is great news for those who are getting vaccinated, and hopefully we'll encourage more to get vaccinated as well. It's encouraging to hear that the data that we are seeing is kind of reflecting the effectiveness that we saw in the clinical trials, and we are seeing that this vaccine in real time, real life settings is just as effective. So of course, there are still some places where that's going to be necessary, right? So if you're in long-term care facilities, nursing homes, other types of healthcare settings, maybe in public transit, you still might be required to wear a mask, which is going to make sense, as well as certain businesses. But as a whole, this is, as we have up here on screen, great day for the country, great day for America, and it's good to see some of the restrictions starting to ease up with the vaccination efforts.
So, Tanner, I think the other good news we have is, which I believe we mentioned this maybe last week, now kids between 12 to 15, ages of 12 to 15, they are able to get Pfizer vaccine. So that's another important step for us. So there are some, what I would like to do for our next week is maybe, you remember what we did with the survey, public survey, just to see how people are, how the parents are actually feeling about this. And there was a study already, but I just want to have one for our own to see what that's going to look like, because it's interesting who wants to get vaccinated, and if they have kids, how they want their kids to be vaccinating. So it would be a good one to share, and we'll probably do that next week.
Certainly.
Well, thank you for the update. So I'm going to ask Richa Sabason. Richa and I, we always fight about her last name. So her last name actually is Sabason, but she wants to go with Shah, which is, I'm on her husband's side, so that's why I go with Sabason, I guess. So Richa, how are you doing?
Good, Kemal, how are you?
Good. So what I would like to do is, we started this the series of different modules of RCM, the revenue cycle management, from the SPM standpoint, from the software standpoint. And part of the reason we did is because there are clients who are utilizing, there are clients who are in transition with Cerner who may be able to actually utilize these services. So we want them to kind of know what we have here. And also for our employees, I think some of these things are kind of good review for us as well. So I think different people are learning from this. So what I would like to do is, before I have you go with your slide. So I made one more generic slide from the United Medical Software standpoint. So our, from our company's operations standpoint, what we use for our communication, which of course includes our revenue cycle management piece, the database and the email, so that we have the database of QuickBase, where there are, for the communication purposes, we have homepage, and then we have a record versus report. And then these things are still being communicated through Microsoft Outlook. And the piece that Richa is gonna kind of do the final overview for us is this middle piece here with the practice management and the PDS, SPM, CPM, but SPM is our focus today. And the other thing is that we also honestly utilize the Microsoft Outlook 365, and for our employees especially, I just want to make sure that this standard folders and rules are being captured or set up properly in their setting, which impacts the overall communication with internally and with our clients. So that's what we have in place. So, but I'm going to actually ask you to just recap what we have discussed in the last 3-4 weeks, and then we'll go from there.
Sure, no problem, Kamal. So over the past few weeks, the senior managers at United Medical have been going over specific topics that are related to SPM. So sort of like the chart that Kamal just showed, this is sort of our interface, so you can say, between our EMR and our PM system. So you can see those arrows going back and forth, and it essentially shows that they communicate with each other through a seamless interface, essentially. And then the arrows at the bottom show our quick base operation, which is what Kamal just described, which is our database. This is where we have all of our reporting and our communication with our clients. So we're utilizing that system to essentially streamline the communication process between us and the practices and us, and then also communicating internally within our teams.
All right,
so this flow chart, I think one of our senior client managers went over a couple of weeks ago. And this essentially shows that everything starts from the doctor's office. So all of the information that is entered for the patient goes through a flow, as you can see here, all the way through a claims process from United Medical to the insurance, and then essentially leading back to either the patient, if they owe anything, or it goes towards, our team to fix the denials or address any rejections and communicate the information back to the insurance companies so that the claims get processed and paid and the doctors get their money.
so I guess the reason for this revenue cycle, this whole thing, as I was drawing, there are so many different steps, but it needs to go back to the client, doctor's office. So we start the process here, and then process comes back to this point, and then this entire thing that we have several different steps are different step the entire operation from the RCM point, which is extremely important for the cash flow for the practices, right?
Absolutely, yeah. It circles back is exactly what you just described. And then in order for that to happen, we use our clearinghouse, which is TriZetto. They have an excellent system that is very easy to use, and you're able to look up all of the checks that you receive from insurances. We get our insurance remittances electronically, and they flow directly to our PM system. So we don't have to do any significant manual posting. All of the information in the ERA is communicated to our PM system. We're also able to see on this system, the claims that were sent every single day. We send claims every day. So we're able to verify whether the claims went through the system accurately. Every single day we check this. So our clearinghouse is an essential part of our revenue cycle process. And then the other piece that's very important is the denial codes. So these are essentially, we can call them correction codes as well, but they basically tell us what is happening with each claim. So if there's any rejections or denials, anything that went wrong in the process, we are able to communicate that information in the system through these codes. And we also communicate that back to the practices. So we let them know, what are the mistakes that are being made most commonly so that they can address those with their staff and hopefully improve to reduce those denials in the future.
So Richa, this piece here, I think just for us to understand why this became complicated is because we have different specialties that we deal with. We have each of these require unique steps, and the reporting has to be flexible, and therefore it needs to be smart enough for us to be able to provide those for the clients. And I think there are about 22 different specialties that we deal with, right?
Yeah, I think it's actually even more, Kamal. I think we might have 25 because we also have some practices that do kind of multi-specialties.
Sure.
But yeah, no, the unique setup is very important, especially for clients that do things that, maybe PCPs don't do, surgery practices, nephrology, um, all of those practices need specific reports because they're not just doing office visits, they're perhaps going to the hospital, they're going to a dialysis center. So our reports are sophisticated enough to be able to communicate that specialty specific information to our practices.
All right. So, and we also discussed the collection process. If you want to just give the overview here as well.
Sure. So Muriel went over this a couple of weeks ago. She's the manager of the collections department, but essentially the collections process helps our practices identify the patients that have overdue balances. That means the balances where we've sent a number of statements, but the patient has not made a payment. So our collections teams reviews those accounts, and then we send over a report to our practices. They can review those reports to make sure that everything looks accurate, and then they go ahead and send them back to us, and we transfer them to a collection agency, a third-party agency. This really helps in keeping the accounts clean in our PM system, and it's very important for accurate financial reporting because if you have a number of overdue balances sitting there that are not making any movement, it is going to affect your overall financial status.
So, Richard, all the stuff that we are doing mainly our main goal, the end goal is, of course, we want to be able to do our job, but we want our clients to be happy. So, and I know we are asking our clients to fill out surveys, and you are in charge of those. We do assign, if there's any bad outcome, we assign those to a director, either yourself or me. And part of that is also, I believe, the reason for our success in terms of our client satisfaction. So what I see here is that we are at like 94%, 94.6%, let's call it 95. So if you round it up. So now some of the stuff that we have here, excuse me, so if you want to take over from here. So this is randomized podiatry.
Sure. Yeah, we received some very positive feedback, which is really helpful for us as well. Even if you give negative feedback, that's also helpful for us. We can address any issues that you may have. But this is one from Brandywine Podiatry, which is, I believe the largest podiatry practice in the entire state of Delaware. And it says here that Besta and Muriel's work, has added to the resources that. With the resources that they have, we've committed to the billing, and the net result has increased the collections, which is obviously, a good goal for almost all practices is to be more successful. And then
So
from Delaware.
Another one that I see is from Delaware Diagnostic Imaging.
Correct. So it says here, overall, United Medical is a professional company that does honest work. That's what we always strive to do. We want to take care of our patients and our practices. And then this is from Dr. James Russell. This was actually during the time when, Kemal, we were doing the almost daily updates during the pandemic, which we're still in. But, when we were doing it every day, Dr. James Russell was very appreciative that we were sharing information pretty much every single day.
So, and we have one from neurology and sleep.
Yeah, so they are very fond of their client manager, Christina Abrams, who's a very smart individual that works at our office. It says here that Christina is our rock. She's always knowledgeable, and if she doesn't know something, she gets an answer. She works closely with us and the providers to make sure that we have every tool to be successful in billing our visits for reimbursement. They obviously are very happy with their services, and all of our managers strive to get these types of reviews. And, to add to that, as you can see, our client managers, there's a specific question on our satisfaction surveys that addresses how the manager themselves are doing. And it's a very high percentage, 97.3% approval rating for being trained, knowledgeable, and able to meet the needs of our clients. And our payment posting team also had rave reviews of almost 95%. So this is a slide that I think, Kemal, you and I had discussed is the potential for increased revenue, right? So we do get SPM clients that are brand new to the PM system, but we also get SPM clients that already have been on the system and are just asking United Medical to take over the billing. So on average, we tell our clients, you might see an increase of 5%, 15%. However, we have seen very commonly that we have revenues of over 20 to 35% increase over a period of 1 to 2 years after we take over. So I actually gave an example of a new podiatry client that joined United Medical in 2018. And I looked at their collections when they started versus the end of the following year that they were with us. And they increased their revenue by 32%, which is very significant. So we work really hard and efficiently to fight for all claims to be paid. That's our goal.
So what I want to actually also share, I'm not going to play the entire thing, but I think the latest video we did with you and 3 of your senior client managers, I'm absolutely in love with that video. I think we did a really good job. So I do want to actually play that a little bit. I think from what we are able to do, we did this internally. So this is all from, we don't have, nonprofit income behind us. So we make everything, we earn everything. So by working more than anyone else, if we were the hospital system, we would pay someone to do this, but we did this with our internal team. It's important. So
they're very talented. They're doing a great job.
They did. And for those who may be interested, they can definitely get this video on our YouTube channel, but I'm going to actually just play a little bit of this. So just want to make sure that the sound is shared. And are you guys able to hear?
Hi, my name is Richa Shah. I am the director of billing operations at United Medical. I've been with the organization for 10 years now. I have been involved in revenue cycle from the onset of my career at United Medical. United Medical was founded in 2005 by our CEO, Kemal Erkan. We are focused on healthier communities and a better infrastructure for all of our practices. Our company is focused on changing the behaviors of our patient population with a fully integrated clinical and financial system that helps increase your revenue cycle management collections every single day. United Medical offers a complete and efficient financial and IT infrastructure. We also offer consulting services.
Campus specializes in special view on our partnerships and service lines. United Medical
is committed to providing pertinent industry updates to all of our clients.
Providers from 23 different specialties across the nation. In 2019 alone, we processed over 1 million claims using our unique denial code system in order to maximize claims processing efficiency. At United Medical, most of our healthcare industry.
So, Richard, I know you guys were able to hear it, right? So I know you couldn't hear me, but I was hoping that video was heard.
Yeah, Kemal, we could hear the sound for the video.
All right. Well, Richard, I know from the medical billing side, our core business now under revenue cycle management, it went through a transformation. And we, as United Medical, we are the frontier and pioneer for many of these in the industry. And I know we are well advanced, but sometimes if the prospect clients don't know, that's where we may fail. So that's why we want to make sure that we make these available. And our partnership with Cerner for the Flowchart and practice management system is extremely also important. I call United Medical almost like a mini Cerner because we have everything from the accountable care organization to the medical billing side, the revenue cycle, and the consulting. And I think we take this very seriously, and Richard, it's always fun to have you, and then thank you for joining me, and we'll see you hopefully in the next couple of weeks.
Thank you, Kemal. Thanks for having me.
Thank you. Bye-bye. So now we are going to start our discussion. My therapy part of the discussion is explaining the difficulties that we go through in healthcare. Many of the providers, many of the people, not providers, but many of the people don't even know the main issues. And we want to actually kind of discuss these issues and make sure that our patients know what's going on, our state officials, they know what's going on, and pretty much everyone. So this is our way of putting our voice out there. So this team of United Medical who works directly with me, they make this extremely easy and fun because getting out here and then talking about these requires preparation. And also we are responsible for what we share. We will never mislead you. That's one thing that we are, that's part of us. So we'll be always honest, and we won't mislead you. So I'm going to share some stuff, kind of maybe some recap of what we did and some additional information from the how the hospital system works, how the emergency system, emergency department works, what they treat. So if you remember from last 2 weeks, we discussed this utilization of the emergency department, which is a big cost. Everything that we do unnecessary is cost. And you may remember this diagram from here. What's avoidable? Avoidable is preventable, non-emergent, and PCP treatable. And many of hospital ED visits can be either preventable or non-emergent, or can be treated by the PCPs. Now, what we see as the going to the ED is more convenient, people are more tend to go directly to the ED. So like Middletown, for example, there's almost like a kind of giant urgent care, I call, but it's a hospital, part of Christiana Hospital. It's easy to get in because it's not in a big complex. So this giant urgent care / aka Christiana Hospital Middletown campus, it's easy to get in, so more people go there from our network. And then, but in Wilmington, that's less. In Laurel Seaford, it's less. So we want to also understand why these people are going. Each blue line here represents a patient. This patient went to the ED 39 times, God bless him or her, 38 times. These are real patients, 33 times, 28 times, 21 times. So this is everything that you see here, every time, every encounter, even the simplest one is $3,000-$4,000. That's the cost. That's extremely costly. So what we ask hospitals to do is stop providing non-emergency service in the emergency setting. So this was not only for Dr. Janice Nevin, but the other hospital CEOs, I say the same thing. Non-emergency is not the hospital business, it's our business, outpatient practices, and that's what we do. So not only we do this very well, we do this less expensively. We have the team of chronic care management where each person is assigned to a care manager who is a nurse, and then by utilizing our database and our EMR, we are able to communicate with our primary care and other specialists and our patients. So we are working on this diagram so that it will be a little bit more in the next couple. But what I also see is for those insurance companies and the state officials. So Tanner, if you are able to join me, so I do want to actually kind of talk to you about the issue that's happening with the risk score and what risk score is, because when we start talking about these, many people are going to say, what the hell is he talking about? And I'm actually already hearing them in my mind, of course. So, but we have this term called risk score, the term called value-based contracts. And that's part of our life. And that's why we are probably doing this now, and then we are also feeling like our voice needs to be heard because there are so many different issues and so many people are doing so many different things. So many organizations are trying to get involved and they are making this more and more complicated. So, and you are in the business development, and then I know that you help the clients for them to understand their quality metrics, their risk scores, and all that. And what we are proposing, and what we are going to lobby on this issue is standardize the risk score factors. Like MSSP here, this is Medicare. It has a different set of risk score formulas, and there's commercial insurances. Like Highmark may have one, Aetna may have one, but they are not same. And there's Medicaids. They have their own mind, and then usually they are less efficient with the state because it's like, I'm not talking about Delaware, but overall Medicaid, like the Medicaid Pennsylvania is horrible. I mean, we are actually lucky in Delaware because Medicaid is pretty efficient and they are actually a good payer. Now, what we are asking is, can we actually uniform these so that providers are not dealing with the difficulty of learning each of the risk scores, because that's all gibberish to them because they don't know. And even for me at my level, and someone who knows the US healthcare system at the highest level, I even have struggles with these. My team has struggled with these. When you are a primary care office with 4 providers and 10 employees, how are you going to have enough time to get all these? So that's why we ask these things to be
Just to mention that you actually had brought up, for anyone who might be watching that's unsure exactly what we mean by standardizing risk scores. These risk scores, the kind of simple terms are just making sure we're accurately capturing the health status of the patient, right? And that comes down to how visits are documented at the time of visit with their PCP, and it goes into accurately capturing the health status through diagnosis, through chronic care management, and making sure, as you mentioned, each of these different payers is going to have their own formula to kind of calculate that. So that's where we're coming from with the mention of standardizing.
So that's, you see, like when we deal with them day to day, so it becomes kind of like a second nature to us, but then not everyone knows what the risk score is. So this is kind of helping us. Like each patient is assigned based on their demographics and their different diagnoses. So that way we can predict what's going to happen in the next year. So so I was told that they are getting a lot of feedback when Tanner is talking. So I'll try to mute while we are doing that. Thank you, Donna. So the risk score is helping us to predict what our spending is going to be in the next 12 months. And that's usually based on the last 12 to 24 months. And then they actually predict. Now, the problem is how those are assigned. Like for the diagnosis, Medicare may be saying one model versus Highmark may be using a different model. So this is Medicare. So when we say, sorry for my bad handwriting. So this Medicare is using a different, they use the ACCs, and that's for Medicare population, mainly on the chronic care issues, and then demographics have set numbers. But when you go to the commercial, now same demographics is going to have a different meaning here, and the same diagnosis may and may not have a different meaning here, and then same thing here. So then providers, like we have, you know how we have 6 different ACO contracts. And then these 6 different ACO contracts are, well, we have Medicare MSSP, Highmark Commercial, Highmark Health Option, Highmark, the Mary Health, Caritas, Humana, and United Health Dual. All 6 have different risk models. So although the idea of value-based is one, but they have there are different languages pretty much. So I have to learn 6 different languages as a healthcare provider to master those contracts. Now you are going to say why this is important. Why do we have to learn, or what happens when we don't learn? So what's really important is many people will have a good understanding. Before, let's say we have a compensation of $100, so this full compensation, this was based on fee for service. Now, this is switched to, they took our $100 that we were making. They said, well, 80 of them is going to be fee for service. And I'm just using this as an example. And then the 20 here is going to be based on the value-based contracts. So in order to make the same amount of money that I made, the practice made last year, I have to learn 6 different languages. So this is $20 here. This is like 20-80, kind of like 80%, 20%. Before, let's say in 2000, the provider in 2017, let's say, in order to make $100, this would be all fee for service. Now in 2021, so there is no this value base is not an incentive system. That's what I want to make sure that people understand. This is taking our compensation that we had prior years, and then they said, well, I think you are not going to make the money that way anymore. You are going to split it, so then we'll pay you $80 based on fee for service and $20 based on value-based contracts. In order to get what I need to make as of last year, I have to learn 6 different models for United Medical, at least, so that I can still make the same amount of money from the healthcare provider standpoint. Does that make sense?
Yeah, that makes sense.
So now we, while we are doing this, what we also have to deal with is another really big issue. And in the next couple of weeks, we are going to actually combine these. We are going to kind of get them all together, so then there will be the pieces will be connected. But what I want to take you from here is, you may remember, not you may remember, you know this, last couple of weeks, we shared the breakdown, how the money is spent in the insurance population. And there's 67 patients that we have, 67. And this is not a mistake, 67 out of 7,700 patient population in the N group is 77, which represents only 1% of the population in that group. We spent 12.7 million. I say we spent because this is how we are being measured. So then that is 20% of the total cost. So 1% is spending 20% of the cost. This is unbelievable. Where do we spend the money? Here. So those under the label of nonprofit, which I still find is extremely interesting. Nonprofit Christiana Hospital made 190 million profit in 2018-19 tax years, fiscal years for them. Prior year 170 million, prior year 100, like you remember the numbers. So when you make 190 million profit, why is that being called nonprofit? So that means they are charging more than what they're supposed to be charging, right? So, but my issue is, how is it affecting us? I don't care what they do with their money, as long as I don't have to pay for it. So this 12 million, which is 20% of the cost, we said, okay, let's see how the kind of like how it's distributed. So cancer related, 5.1 million. Do you know how many patients this total is for? 30. And then heart attack, 1.4. I think it was 11 patients, if I'm not mistaken. And then 1.1 for the spinal, and then we couldn't actually just group these. These are patients are staying in the hospital. Some of them have sepsis and other stuff. Now, what we are saying here, and also, from our employees' standpoint too, I want them to understand what their leadership team has to deal with. This is what we have to, because hospital has to make, hospital also gives higher compensation for employment, higher benefits for the employment. So then there is this unfair competition being generated with these practices, with these organizations. But how they do that is by taking from the public. So there's no such thing called nonprofit. It's all about their financials, their money, their CEOs making more than $2 million a year, their former CEOs being paid $3.4 million, and this is the reality of our world, actually. So, and then I'm just using this outlet as, look, this is what we have to deal with. So, can you help us, state officials? So, I'm going to tell you one of the other things. Why I have to actually make a big deal out of this is because it's affecting everything else. Now, as a private organization, we were one of the first ACOs, accountable care organizations in the state. So I'm going to actually just share something. I'm going to skip this lobbying piece. I may come back to that because I don't want to actually miss the opportunity of this really important issue for us. Because of all these, there's so much money involved, I think. And then I need to make sure that our team tells us if the echoing is better.
Okay, may have fixed it.
Okay. So
hopefully, fingers crossed.
The way that why this bothers us, because even my family, my brother-in-law the other day, he's like, why are you so aggressive with the hospitals? I'm like, well, because they're trying to take business away from us. So I'm going to give you an example. I built this network based on the values of the accountable care organization in 2006. Now, there's prior time with our other company called Blue Ox, and at that time I had a cardiologist who was in charge of the operations, and it was his vision, but he wasn't able to move on, so we were able to take over from that point. And so when we actually were the pioneer of this system, and we adopted first. We were not given $1 from any of the government entities, no nonprofit benefits, nothing. We, just like a real soldier, almost like we fought. And then hospitals have all these different crazy toys, and then they attack as much as they can. Now, what happened is, Tanner, you may not know this, so I'm going to kind of explain this to you.
Sure.
And then you'll understand why this is being shared now. So in 2017, we were the only ACO under the Medicaid health option and the United Health Unison, that time called, and we were the first one. No other organization had value-based contract with Medicaid. Again, 2017, not 2017. 2018 to 2020, Unison left, Mary Health Caritas came, and then our first condition was we have to have value-based contract, and they are a managed care organization for Medicaid, and health option was there as well. And then UMACO, for those 3 years, the only Medicaid ACO through the 2 managed care organizations. And then what happened was, when we get to the payer level, at Medicaid level, there was an application so that they said, well, Medicaid now wants to certify the ACOs. Now, keep in mind that 17, 18, 19, 20, 4 years, I'm the only one as United Medical. state did not approve us. And we were the only one who was not approved for the certification in 2020. We have 4 years of experience with the Medicaid population. We are the only one with the organic EMR, with the shared, integrated EMR. I mean, everyone looks at us like they want to be like us, and then Medicaid disqualified us for the first year. Now we are on the second year, and now why that happened? Well, who is in charge of those committees? More than half of them are Christiana Hospital people. Publicly, Christiana Hospital board member, under the West Side name, she opposed to the physician that I nominated when I was asked by the state. And then she publicly said that, well, this is not a good option for us. There was no good reason. And then the reason on the paper was, oh, it's not a practicing provider. Are you kidding me? The guy does like 200 at least bariatric cases, 200 general surgery cases, actually who's also coming in 10 minutes for today's session. He sees at least 150 patients a week. He's on call. He's the one who set up the surgeons for emergency care, the 24/7 surgeon surgical practice. And then Miss Lolita Lopez says, oh, you're not qualified, but you're not a practicing provider. And that's what I'm afraid of. These are happening under the name of Christiana Hospital or other hospitals. You know, it's so interesting. Like all these hospitals are all together now for their ACO purpose. They compete with everywhere else. Yet, when it comes to ACO, they are together because we know that when the ACOs are successful, hospitals are going to lose, and they are sabotaging as much as they want.
So it sounds like, Kemal, this is another issue kind of tying back to the ongoing conversation that we've had with and trying to continue the conversation around the ACO representation at the state level when it comes to the health committees and who exactly is supporting these committees and the affairs that these committees take on behalf of primary care in the state of Delaware, right?
You are seeing my next slide. So what we would like to have is this is why we would like to have equal chance in the state committees, healthcare committees, decision-making committees. So this is, again, like what I was saying in the next couple of, all these pieces will be connected with the time permit or time being kind of limited, we can only do so much and then little pieces. But when you look at it, the overall picture, right now, what we have is healthcare committees through state of Delaware as payer and hospital based. Payers are insurance companies, so that group GSSC, Medicaid Managed Care Organization GSSC, another Medicaid Managed Care Organization GSSC, Aetna GSSC, and then hospital, every hospital besides GSSC. Not people is we have another session coming up in 10 minutes. That's 7 minutes actually. So if you want to actually learn about the bariatric support group, the support group aspect of bariatric surgery, and also I'm going to share some of my personal fitness issues, and Dr. Erkan is going to help us to analyze those at the support group level. I'm going to actually have my little support group meeting with him. We are going to come back with these issues, and we are already working with state officials. We will not let this happen this time because we also learn a lot. It's not the same United Medical in 2012 when we were told by one of the medical directors of one of the biggest insurance companies, what you are proposing is not helping us because I'm not an insurance company, I'm a TPA, third-party administrator. So that was 10 years ago. Well, we learned a lot since then. So, and then we'll be coming back with more updates. And thanks for being with us. And we'll see you next Friday. And Tanner, thank you for helping me with all the stuff that we presented.
Sure.
So that's where we are for today. Well, have a nice weekend. I know the mask requirement is off, but be careful, be conscious, because just because the mask is not required, although like in public transportation, it is still required, you still need to protect yourself and your families and others too. So get vaccinated, complete your vaccination, and then tell us what else we can do, what more we can do for you, and communicate with us. So that's what we would like to see. We'll be back in a couple minutes, and that's for the bariatric, and then for this event, we'll see you next week. Thank you.